Good evening. Welcome to the joint City of Indianola City Council meeting and IMU Board of Trustees meeting. It's March 10th. Glad you could be here. If you will please stand and join me in saying the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Jackie, would you please call the roll?
Councilmember Hewlin.
Here.
Parker.
Present.
Kling. Schroeder.
Present.
Southall.
You're on Zoom.
Marchant.
Present.
Board Member Forbush.
Present.
Richardson.
Present.
Boyce.
Present.
Rosga.
Yes.
Smith.
Present.
Mayor Pepper.
Present. Wonderful. The purpose of tonight is to do some discussing on the 2021 health insurance renewal. So I will turn that over to whomever. Courtney! Great, we'll take you.
Just really quickly, if I would introduce myself, it's great to be here. I'm the new Human Resources Director for the City of Indianola. My name is Courtney Silliman, and I have the pleasure of introducing Gail and Alicia. They're going to give us some information on budget, benchmarking, COVID, and 2021 considerations. So thank you for being here.
So thanks for the opportunity to be here. I typically start out saying, ask any question at any time, because if you're thinking about it, probably someone else is too, so let's get it on the table. But my intention tonight is to walk everybody through the 4 topics in such a manner that the questions will be answered as we turn the page. So if we could hold off on the question till we get to the end, and then we'll have general discussion. Is that fair? Okay, good. So then I want to secondly say that we're not going to talk about the renewal per se, because we don't have the renewal numbers per se. So we anticipate getting them in March at some time through the month, and then we will do a process which is outlined here. So we're going to talk a little bit about the background, where your benefits plan has been. We're going to talk about where we see it going, and we're going to come to a consensus. At least that's my intention. Everybody okay with that? All right. So if you turn your page, everybody has this information. I guess I'm on
We actually
paper.
have it up here.
Okay, I'm the only one on paper because I am OLD. Okay, so we have an agenda here. As said, we're going to talk a little bit about home Smurfy, not so much. You guys have seen me. We're going to talk about the benefit review. We're going to talk about benchmarking. We're going to talk about COVID-19 and the impact on your organization, and talk about 2021 considerations. The next page is our service team. I've been here before. We also have backup for myself. We have backup for Alicia. We have backup with a lot of experts out of our Dallas office and out of our Des Moines office. So I want to turn now, which is page 4, to you. The current benefits are outlined here. On a medical basis, we're self-funded. We have one plan option. That option is a qualified high deductible health plan. Just for background, a qualified high deductible health plan allows our people, our employees, to set up a HSA, which is a health savings account. That is a $2,800, and that's inclusive of everything. So you'll see me later on comparing your health plan to other contemporary plans, and I'm going to address any differences or discrepancies that you have. You have a qualified high deductible health plan. You do not have a traditional health plan, okay? And your dental, and that's through Wellmark Blue Cross Blue Shield, and it renews in July. Your dental is fully insured through MetLife, also renewing in July. Vision is fully insured, Avisa's July renewal. You have basic life and AD&D, accidental death and dismemberment, that is classed out. So if you're a class 1 non-union, it's one-time salary to $45,000. If you're a class 2, which is union, it's a flat $15,000, includes dependent life benefits through Mutual of Omaha, renews July. Voluntary life available to all employees, also through Mutual, July 1 renewal. Short-term disability is employer paid through Mutual, July renewal. Long-term disability, employer paid, Mutual, July 1 renewal. flexible spending account. You can see the limits there. And they typically are indexed every year. COVID makes things interesting. So those are the limits as they stand today. And then COBRA is offering an offering to our employees who leave us. Okay. So page 5, this is our annual timeline. This is what we do with every account. Put a timeline together, a little different if you're self-funded. And I didn't mention that your medical is self-funded, kind of a difference in philosophy there, different expectations. We look at renewals a little differently. We look at timelines a little differently. We'll walk you through that. So we typically start strategic planning in November through February, about halfway through. We've done some of those meetings. We had a pre-renewal meeting that was done in February. The board meeting, which is today. The next steps, we will discuss the renewal as we get it. It comes in different times through March from all the companies that I mentioned. We don't just have one day, they all pop up. We will have renewal and budgeting meetings in late March and April, final benefit decisions in April, and then we'll go to open enrollment through the month of May. Okay, that's typically our process. Okay, so now page 6, budget. So I want to talk about where you've been, because this is critical to understanding. It doesn't matter if it's my savings account or your savings account. It doesn't matter what we're talking about. We need to look at the historical to move forward. So I have here the last 7 years. You can see at the top, annual year or plan year 2013, 14, 15, all the way across. The next column is the average employee count. So you can see we've had a little variance. In 13, we had 95 employees, 14, 91, 15, 90, 16, 93, 92, 98. And in last year, we had 103, and year to date, we have 105, okay? So the reason why I point the budget out, because costs vary by the number of employees. We have fixed costs when you're self-funded. We have fixed costs that you pay no matter what. You don't have a claim, you're still paying a fixed cost, okay? And I'll get into that. But I want to point out why we have these lines of demarcation. The very next column is claim cost on a per employee per month basis. If Ryan is the employee, this is a claim cost per employee. You see this both ways in our industry. You see it per employee and you see it per member. So Ryan is the employee. If we're talking about Ryan's wife and Ryan's 2 children and they're covered under this plan, they would be members per member per month. But today we're talking per employee per month. Claim cost. So this is actual claim cost. This is not an administrative association. This is just the actual claims. So 2013, you can all see we had $960 per employee per month. Went up a little bit in 91, and you can see directly below that the increase, the change. If it's a red number, not so good. If it's a green number, things are better. So we had a 0.7 of a change from those 2 years. When you look at 15, we had less employees, and we had a 22.6% increase in claims. So there we were up like 1,185,000 claim costs, okay? The next year, better year, 694. The next year, 587. The next year, 764. So you see again, that's a red number. And then this year to date, which is 8 months of information, right? 604, and it's better. So those are actual claim costs per employee per month. Now, the next thing we look at, the column below that, is claim plus fixed cost. Fixed costs we pay no matter what. Even if we don't have a dime in claim, we still have fixed costs. Those fixed costs would be reinsurance. We have stop loss reinsurance, which, just so you would know, aggregate and spec. Spec means specific claim. We pay reinsurance to stop every claim at a certain dollar amount. If that claim comes in at $1.5 million, we're paying only that dollar amount, right? And then aggregate is all claims at some percentage of expected. So if we expect, let's just say 1 million in claims, we're going to stop all those claims at 25% of expected. So we're going to pay that just like your auto insurance. You're paying your auto insurance and you haven't had one claim, right? A fixed cost. So that column we're looking at there is the claim plus the fixed cost. And if you have more employees, your fixed cost goes up because they are also per employee per month. So we add that up, and you can see like for 2013, our fixed costs are 1 million plus claim, 1,172,000. Directly below that is the number that was accrued. Okay, so that was what the budget accrual was for both claims and fixed cost. And below that is a percentage, and that shows what it was to accrual. Okay, everybody with me on that? So let's just take a look at that budget and accrual. So you can see in 2013, our budget and accrual was $1.3 million. It was the same thing in 14, $1.3 million. Same thing in 15, $1.3 million. Same thing in 16, $1.3 million. We did not change our accrual for those years at all, regardless of claim, regardless of anything. We kept the same accrual. Okay, now take a look at 2017. We had a worse year. Why did our accrual go down? We had more claims. Why did our accrual go down? This is a significant question. The accrual went down for a couple of different reasons. One, we switched plan design. That was the year we changed the plan. We made adjustments to copays. We changed the deductible, which in this case, we changed the out-of-pocket maximum. We also changed from United Healthcare to Wellmark, so our fixed costs went down. Okay, so the natural is, you're just looking at these numbers, the natural is, holy moly, why did we accrue less when our claims had been up the year before? But that's why. So I hope I answered that question for you. So you can see all the way across. You can see at the bottom of that numbers what the percentage of claims were to accrual.
Question.
Yeah.
So this budget to accrual line item, you're saying 1.3 million. I thought that was per employee.
Well, that was in total.
So the way
But that's not what we're looking at, $1,365.71.
it is, yeah, it is, that is a per employee per month, so it's around 1,300 with enrollment around 100 employees. But you're right, it's a per employee per month, so we were setting aside $1,300 per employee per month.
That's fine,
Yeah.
I understood you to say 1.3 million, and
I'm
that's
sorry,
not
I
what we're.
probably did, and then
Okay.
it wasn't right, so thank
No,
you for
I just
correcting
wanted to
me.
make sure I
probably
understood.
did say that, yeah. Maybe I should put my glasses on. Wrong ones. Okay. So the highlights of this page then we put down for you below. Funding did not change from 2013 through 2017. We had back-to-back plan years, 2015 and 2017, where accrual was not enough to meet expenses. We made plan changes in 2017 and changed carriers. We updated accrual to ensure adequate funding available, and the plan has run better since the changes were made. Okay. So now we're going to be talking from the next page. This is kind of the transition I want to make here, is that this next slide is looking at where we need to go and what we need to look at to continue our plan. Okay. So what we need to do then is determine an average and base that average on budgeting for future. So we're going to look at the last 2-year averages. So you can see in the upper right-hand corner, 2018 and 2019, the claim cost, $587 versus next year, $764. And we're going to take that and we're going to average that out to 675. That was the last 2 years of average. Our average employment for 2021 is 105 people. So the average, the prior 2-year average at 6 months is 425. Adding those up, take a far right, $675.99 times 105 employees times 6 months gets us to $425,871. That is the beginning fund balance we need each and every year. The annual budget for 20 to 21 was $1.7 million. So if we take the fund balance needed each year, 425, and then the budget is $1.7 million, that gets us to $2,145,000. That's reserve plus 12 months of funding. Now you're going to ask me, why don't we ever see that $2,145,000, Gail? Why don't we ever see that number? Well, we don't see that number because claims are coming in, money's going out. Claims are coming in, money's going out. That's one reason. The other reason is we accrue each month. It's not like we write a check for $2,175,000 and put it in the beginning of the year. We don't do that. We accrue on a month-to-month basis. Claims come in, money goes out, accrual goes in. Any question on that? And this is kind of pivotal that we don't ever see that $2,145,000. Okay, so then what we want to do then is we want to get to an average because we don't want to have this fluctuation of enrollment. You know, we go from 93 to 105, and I think that this year we actually budgeted for 5 or 6 or 7 more employees than we actually hired. Can you tell me what it was? 5 or 6. So we've accrued these people, we're funding these people without a claim, we're paying fixed cost, and then we're accruing for their claims. We didn't hire them, we don't have that expense. So we want to get on an average of claim cost per employee per month and an average of employee per month. So we don't accrue for people we don't have. Does that make sense? If we're budgeting Christmas money for 10 kids and we only have 8, we're going to have more. We don't want that. We want to have an accurate and active budget. So we recommend taking a look at per member per month claims instead of total claims. We also recommend taking a look at average enrollment instead of current or projected for the future. Everybody with me on that?
Per employee or per member?
Per employee. Okay. So Holmes Murphy, we have a budget model tool that we use, and we are going to account for these changes by average claim cost per employee per month and average employee. We do this. You're going to ask me, why don't we accrue? You're going to ask me, why don't we accrue fixed costs? We don't need to accrue fixed costs because that's in the budgeting model. We don't need to accrue for a fixed cost. We don't need to, we don't need to reserve for a fixed cost. It's in the budgeting model and it will be accrued. Does that make sense? Why are we only looking at claims for reserve? Because we're going to accrue for the admin on the monthly budgeting. We don't want to put it over here because it's over here. It's as simple as that. We've got it in this bucket, in the rate making and the budgeting. We don't need to reserve for it. Okay? So you guys, you're the city, the IMU, you get to determine where the budget is set based on the tool outputs. And last year we budgeted at 60th percentile, meaning 60% of the time the budget was enough to pay claims in the prior 3 years. Okay, so let's just say January, February, March, we're below accrual. We're going to use those dollars to pay for the times when we need it to pull from other months. In our industry, self-funding, we look at 3 different dollar amounts. We look at the 25th percentile, we look at the 50th percentile, we look at the 60th percentile in terms of where we need reserves to pay for claims. You guys, last year we did 60%. This is a very conservative nature. This is very conservative. Just want you to know that. Okay. So down at the bottom, I got an asterisk that the prior 2-year claims does not include admin fees. And I hope I've explained that to you. We're not going to reserve admin because that's done through the budgeting tool. Okay. All right.
Really quick, with the budgeting at the 60th percentile, what that means is because we're self-insured, we are the ones, we will get information from the carrier and from Holmes Murphy that will say, based on your history, the claims will be, we expect them to be this, and then your max exposure is this point. So setting it within those rates. And so when Gail talked, and a number of you were on council or on the IMU board, when we went through the exercise to revamp the plan design. And Gail had previously presented that what historically the city was doing was the industry was saying you should budget at this amount to this amount, and the city was budgeting under that amount. And so that's what Gail was alluding to on one of the previous slides, but that 60th percentile is within the expected to the maximum.
And
But it leans towards the maximum, right?
and
To your
it,
point of being conservative.
it means that 60% of the time, every month, you can have the fund for that month to pay for the claims for that month. Now, take a look back this year, ladies and gentlemen, take a look back, last year, starting this week, this was the last real week we had in the last 365 days. So many elective surgeries were postponed. We didn't have hospitalizations in March and April and June and March, April, May, and we didn't have people going to the doctor. The health conditions were still there. So those were those months where the accrual was higher, and we certainly had more than 60% at any point in time to pay those claims. Okay.
I will add in, just since I have this in front of me, Adam, to your question, last year the Wellmark expected was around 1.68 and max was around 1.98. So the 1.72 was
In the middle.
probably right in that sweet spot.
Okay. So now I'm going to page 8, and I think this will answer many people's questions. I hope it does. Budget takeaways. So here is the takeaways. Based on where we are today, the city can likely hold rates flat for the 21 renewal. And by saying rate, I'm saying both the employer contribution and the employee contribution. That's up to you to do how you want to do that split. We're saying we believe it's likely you can hold rates. Now, I do want to say we don't have the renewal, and you've been running very well, but I want to point out that stop loss reinsurance is on it has a global impact and a global factor. It's not just Iowa, South Dakota, Wellmark renewal. It's reinsurance is global. I mean, we'll have companies that take 10 million X of 10. We'll have Swiss companies that take 20 million X of 50. I mean, it's global. And when you're in a pandemic, we're gonna have a rate. I believe we're gonna have a rate increase on our stop loss, just from what I'm seeing other companies. And again, stop loss reinsurance is a global basis. It's just not Wellmark. It's not Iowa, South Dakota. It's bigger than that. So I anticipate a renewal increase in at least part of that. I don't have it in front of me. I don't have it, but I do feel like, a normal renewal, we're likely to hold the rates. I do not recommend decreasing from current to avoid situations similar to 15-16, but I'm certainly willing to look into it next year if we continue with the same year we have. I want to remind you, when I said about COVID already, we had a lot fewer claims, May, June, July, August, September, but the appetite for that surgery, the need for that surgery, the need for that care has not gone away. So we may see higher claims when this opens up again. We have been seeing it. A lot of our companies, we've seen claims going up January, February, March, etc. So keep that in mind, because we had a good year doesn't mean that we're going to continue having a good year, because this need and appetite for surgery is going to be there. It's just been delayed. That makes sense, doesn't it? Okay. So now I'm down to the third takeaway. The 2020 accrual was in line with what Wellmark expected. It was in line. Okay. And as a reminder, the city we have purchased terminal liability in case you ever want to walk away from self-funding and take an insured product again. Some of you understand that claims are paid in different years than calendar and policy year. We do have terminal liability. As I said, we don't have the 2021 renewal, but due to industry trends, we are expecting to see an increase in stop loss. Fixed costs may go up, but it will not be a large dollar amount. Okay. Claim projections may go up because of this appetite, as I said, for pending medical care. So once renewals are received, we'll be able to determine recommended fund balance and 21 rates. So that's kind of where we are. I suppose you have questions now, like how much money is in the fund?
Okay, how much money is in the fund?
Thank you. So, all right, so year to date, and these numbers were supplied to us by the city. We do not keep that money. We do not control that. We do not have any information on that account. That comes directly to us. Year to date, there's 1.8 million in the account. It started at the beginning of our policy year with 1.3 million. An additional 1.2 million has been added July, August, September, October, November, January, February, and 675,000 went out of that account in claims. So year to date, as of today, supplied by the city, it is 1.8 million.
And that was the Fund 820 attachment that was sent out to everybody.
So can we have some discussion on that? Because the approach that was taken on the budget sheet that you had in your presentation made total sense to me. And
This
and
presentation?
Yeah, and I agree with the approach that you took to calculate what the reserve balance should be. But based on that, it's at 425,000 compared to what we just talked about being, and we're projecting, I think, over 2 million at the end of this fiscal year in the reserve. And so that kind of makes me circle back to, well, you're suggesting that our rates aren't going to need to increase. And I'm kind of like, it almost seems like we've been overcharged because we've been building this reserve. And so IMU and our employees have been paying more than what's needed because we've been growing this reserve and don't need to, based on what the reserve suggestion is.
So if I can, and then you can jump in. So remember when we started the process, there was virtually no reserves period. So what the reserve policy and the reserve number that Gail showed in that calculation, that is the city's policy, and that's what we've been striving for. So I don't know if you can go back to that slide. That, so go back up to the PowerPoint.
I think number 6.
Is it on page 6? You gotta go off the screen the way it's set up. Yeah, it's,
I'm sorry.
yeah, no, because it's set up on it too.
Yeah.
There it is. Okay.
So so what they're saying is this is that beginning fund balance, but that's our cost. So that together is that's what's in that 820.
And see, I don't agree with that, because I think it's only the 425 that should be in the 820 at any one time.
But the 820 is where everything, so the way when the city departments, same, I don't know how IMU has their budget, but like our police department, that expense per employee is there. That department is charged that expense, and then that revenue goes into that fund to pay the monthly thing. And so that happens. So what is here is the budget that you're accounting for all the expenses and the revenue that's coming in. So this is not extra money. The 2 point is not extra money that's sitting in a fund that's not earmarked. That's all the revenue from the employees, the charges in the Department of Budgets coming into this fund, and this is where those expenses come out of.
But that $1,720,000 is just assumed to be coming in throughout the year, like what you were just talking about. And at the beginning of the year, all you should need is that reserve amount. So at last June 30, we would have only needed 425,000, and yet we had 1,231,000 in the reserve.
Say that again. As of when?
As of the end of what ended on June 30th, 2021.
20.
And we can, yes, I'm sorry, 20.
Yep.
You're right. And I said the wrong number. It's actually 1,005,000.
Mm-hmm. Right, and I think a lot of that, in that particular situation, that has a lot to do with with a lot of the staffing holes that Gail was mentioning about, especially due to COVID. So we still have those expenses built into our budget for the operating departments, and they're still getting transferred in to this fund.
But there were probably less claims
Right.
going out, spending
Right.
money out.
Right.
So that's why that account was healthier at June 30th.
Yeah,
But we're projecting to grow that by another 800,000 this year.
So, but you gotta, when you're looking at the 820 fund sheet, the final fund balance, maybe we're calling it the wrong thing, the 2 million, so the draft budget, right?
We estimated, yep.
So the beginning fund balance, that's incorporating all the revenue coming in from all the departments for those per employee costs. So it's not a true fund balance, it's not a reserve. So that's accounting for that 1.7, let's just hypothetically speak, that would be the 1.7 plus what's remaining in the reserves. So if we stripped out all the departmental expenses, all the employee costs, that's what the target would be. So you're just seeing all that we budgeted transferred in and accounted for in this budget. So it's not reserves, it's not extra cash that's available. It is earmarked for those employee costs that are already built into the budget. So it's not just cash on hand that's not allocated to a particular expense.
But if our claims activity through the rest of this year turns out the way it's expected and the re-estimated, we will have over $2 million sitting there in cash, right?
We will have the 12 months worth of funding for the health insurance expenses plus that reserve target. But that's the other thing that Gail's saying is we won't be able to tell you that until we have the renewals, because then we will know what the per employee cost is, and then we will know how much extra or how much more is needed. So there's I don't know how else to explain it, other than that this number accounts for all the costs per employee plus the 425,000 of what we should have.
Let me ask the question maybe a different way. So let's say that we need, I can't read that number, 2,145,000,
Yep.
whatever it is. Help me understand the scenario where that would be depleted, where we, in 1 year's time, we would need all of those funds. I mean, we would just have to have an astronomically bad year in claims, and I have a hard time understanding how we would get there, given our stop loss coverage that's going to prevent that from happening.
I have a little bit more experience here on this, but so at one point we were at that level of 425 in that fund, and we were told then if it dropped any lower, they were going to step in and force us to take. So in other words, we needed to be closer to 1.6, 1.8 at that time is what we were told, and so that's why we were building that back up, you know, and it's to be able to then cover those costs. I guess that's just, I mean, I'm basing it off of that because we were at 425 at one time and they were like, it gets any lower and you're going to be done with your self-funding. I think you were on council at the same time.
Yep.
So, I mean, I guess.
This is kind of unrelated to that particular, but I mean, wouldn't one cancer patient
Yes.
put that, I mean?
No,
No, 'cause it goes
you would
to-
have stop loss that would cover
Right.
that.
Oh,
Yeah.
the stop
To
loss.
become a
yeah.
laser, but yeah.
Okay.
But you also have the run out claims too. That's the other thing to remember is that it's just because somebody goes to a doctor on day one doesn't mean that the bill is being charged to our account. What was it? Back up to 2 years that we can, is it 2 years?
A year.
A year. So you're still paying, we could still be paying for claims that happened last year. And that's outside of our control. So what happens is the doctor's office has a particular time within which to file it with the insurance company. And then the insurance company goes back and forth, and then we would ultimately get the bill. So you're still paying a year in advance as well as stuff during the current fiscal year.
I get what you're saying, John. I mean, the pendulum has kind of swung in my view, though.
Right.
We were not having enough in there. I get that.
Right.
But in my view, we've swung too far to the other side, and we're growing it more than I think we need to. And all I'm saying is we need to swing back to the middle.
And I think, I mean, and I don't disagree with you there. I think that's what she was trying to say was not yet, but probably next year we would look at, once everything kind of settles out to see exactly where it's going to be with the next guy, because I don't disagree with you. I mean, I think we've done a great job just in a few years to get where we are.
I think we did what we needed to.
Right. Yep. No, I don't disagree with you. I don't disagree with you there.
Yeah, but also please look at year-to-date 2020. We've got 8 months of claims experience, and we're running well at this year, but like I said, there's a pent-up desire for this elective surgery that we're going to see. I don't know if we'll see it yet in May, June, and July February, March, April, and May, June of this year, but we're going to see it. You can.
Gail, are you talking about that spreadsheet that you have, the monthly experience report?
This one here.
No, this one.
Yep.
That was sent out earlier. It has every month from July to January filled out, except for February to July of 2021. It shows that our total so far this year is 713,000. Each year, each month we've been about, it fluctuates between roughly 80,000, anywhere from 80,000 to 120,000 each month. Now, if I base my projection on my reimbursement on 5 more months of 100,000, that's where I get the 1.2 million. But as Gail's mentioning, there's
Anybody that can read that, I'll buy them.
desire to do more. Is that what you're saying, Gail?
Yeah. I mean, elective surgery can be put out. I have to have my knee replaced. Well, and I'm in pain, and I wanted it done last year in April, but man, COVID and the hospitals were saying they couldn't take me, and now it's wintertime. I don't want to have my knee done and walk around on ice and snow, so I'm going to wait, see if this COVID thing gets a little better. Maybe I'll look at it in June or July. That has not changed. The need for these surgeries, elective surgeries, it's not been eradicated. It's just been pushed back.
So what Adam is saying is correct, and we've done, and John added to, is that we've done a really good job as far as building up this fund balance, and the fact that I may have underestimated here based on what you're saying that now, as far as some pent up desire to have more stuff done. I'm basing it on what we've had experience with for the last few months. You're saying that there might be even more.
Yeah, I've seen it on other cases that I've had. I've seen it start ticking up in January. They get through the holidays. I've seen it tick up in January and tick up in February. And I assume that the months where we had little activity last year, March, April, May, June, July, many of the hospitals were not taking anything but emergency. Folks remember that? And like the Mercy system across the state of Iowa said, we're not doing any electives. We're going to hold those rooms for COVID. And that's exactly what happened. So there were, and as you can read the paper, the hospitals became grossly under budget because there was no revenue coming in. So the need has not changed. It's just been pushed back.
And I agree with that. And I think that probably is true, but it seems like it's continuing to be pushed back more and more because it's not showing up when people are expecting.
They say 6-7 months ahead.
Yeah.
I mean,
yeah. Because I'm seeing the same thing at my employer, and I see all the same stuff there, and we're having the same experience. And even when the hospitals open back up and you can have those elective surgeries, it's not happening.
Adam, what do you think the reserve should be? Like, what's your comfort level? Is that 2.1?
I hear what you're saying about the 425 being too low. It being over $2 million just seems awfully high when our claims, if you look at the history in claims, it only varies by $300,000 to $400,000 a year. So I understand that there's a desire not to go down all the way to the 425, but when there's very little variance from year to year. I don't understand why we need $2 million sitting in cash.
So what was the recommendation? 1.7, 1.8?
Yeah. So we're in a much different position than we were 5 years ago when I was hired. I was sitting right over there. My first council meeting, I hadn't even stepped foot in City Hall officially. And council held up a graph showing that it was being completed, and this was one of the first things that we worked on. So what's nice is we're at a position where we can have these conversations and it's not triage because, and I gotta say, the employees have done a fantastic job of embracing this plan, embracing the wellness program, going and being wise consumers, which is what the purpose of the high deductible health plan is. It's a consumer-driven plan. And the employees have done a fantastic job. They're the reasons why our claims are what they are, and we're able to have this conversation. I think perhaps we can look at a different way of showing it as a budget, because I hear what you're saying, but it's not just $2 million sitting in cash that's available. It's earmarked. It is tied to the per employee cost. So really, if we stripped out those costs.
I'm sorry to interrupt you, Ryan, but can you help me understand that? Because it seems to me that there really is, like right now, year to date, there's $1.8 million sitting in cash. So, but you're saying something different. I'm just trying to understand that.
And this goes down to the way we operate our budget. So at the start of the year, all the employees, all the departmental budgets are built based on the employee. What's the compensation, what's the benefits? Those benefits then are expenses to the budget. And then as they're expenses, that money is transferred in. So police officer A is assigned this cost. That expense is transferred from that and put into the Fund 820.
But it's done each month, right?
Is it done each month?
Yeah.
So what you're seeing is the high level, the budget. I mean, so like if you look at the far right, I don't have any more, but it's like the draft budget shows this, and then the ending fund is like 2 point something, right? So that's the high level overall, all in what the transfer would be coming from those departments into, and that's the revenue and the expense for those employees.
But if claims end up to be what we're projecting, there will physically be $2 million in cash sitting in the bank account on June 30, 2021.
Well, I'd have to say, Adam, that it'd probably be a little bit less than that. It's based on what Gail's numbers on that table. And I made this spreadsheet up prior to seeing Gail's numbers there in that spreadsheet. But if we have 100,000 each month for 5 more months, that's 1,036,000, probably going to be closer to 1.2.
And I get that. Hey, I'm just saying if claims are what is on this sheet, I get it may be different than that.
But again, you can't discount the fact that we do have claims from the prior year that we still can get billed for. So there's that factoring in as well.
But then you're going to continue to get premiums from employees, from IMU, from the city that are going to go into the 820 fund that will help fund those claims too.
But you wouldn't want to have the premiums from current employees pay for premiums from the previous employees or previous claims.
But that's really what's happening now.
The premiums are paying for the cost of the employees as we're going along. And so if we drop that down, now what you're doing is you're having a situation where you're needing to raise the premiums or bring in the premiums in order to pay for stuff that wasn't accounted for. But going back to the point of what Gail mentioned is, and I think it was on the next slide here. Yeah, so when we started this a couple of years ago, the recommendation was to have 2 years worth of claims. And we knew we had to build that up. And then as part of, when Gail mentioned the strategy meeting, one of the things we talked about was, okay, we've got every year we look at our financial policies, and this is what the financial policy says. And can you take a look at it? Does it still meet the recommendation that you're saying we should do? So when they looked at that, it's, no, actually we're good. And that's why that last slide, and that's why Gail's saying, based on where we're at today, we can probably hold those rates flat. Once we get the renewals, we come back and you guys have that discussion of are we good? You know, we could have horrible claims from here on out and our renewal goes back up. Well, then we won't have that fund balance. So,
And what I'm saying is, it's unlikely that that scenario is gonna eat up $2 million of fund balance in 1 year's period of time. The most it's gonna be impacted is negatively is 300 to 500,000 based on the history of claims that we have. Am I off base on that statement?
No, because as a reminder, you guys have aggregate protection. So for the 2020 year, your maximum amount that you're gonna pay in claims is 1.9 million. Because Walmart is gonna reinsure any claim for anybody once the group together has hit 1.9 million in
So-
claims.
And that's a very important point. I'm glad you pointed that out. So
Yes.
the max we're gonna pay is $1.9 million, and we're bringing in premiums of 1.6, 1.7.
right,
But then we've got 2 million on top of that we have just in case. That's where I'm struggling.
I think that's where there's a disconnect, because we're not saying that's, maybe this is a better conversation one-on-one offline, because we can walk you through the methodology of the budget. Because it's not.
I get the methodology of the budget.
But it's, that's the thing, it's not true fund balance, it's not,
There isn't 2 million.
right.
There's not an extra 2 million just
Right.
sitting there.
Yeah, and I mean, if you look at the handout, the Fund 820 handout that was done, the revenues coming in is 1.8, the expense is 1.9 or whatever, that, maybe I got it reversed. So, in that particular case, we are spending down that, and then it shows in the bottom right, somewhere like 2 million.
But year to date, the actual ending balance is just under 1.8 million. That 1.8 is cash sitting in the bank. Am I off base, Andy? Is that correct?
That's how much there is in the fund.
Yeah.
And you gotta realize that's restricted too. That's for health insurance premiums and anything, any claims that would come in.
So is there a regulation from a municipal city standpoint that those funds are restricted and can't be used for other things?
Yeah, we don't.
Like, I'm not suggesting the city council would do this,
But
but
that's why that fund's set aside. That's why it's an internal service fund.
Okay.
That we cannot spend that money for anything other than health insurance.
When people retire, do they get buyout on that? Or do they just keep that? Do they continue to own that health savings account?
The health savings account is part of that plan design change they did previously. City-IMU had a longstanding program where an HRA, health reimbursement account, was promised to the employees, but it was a liability on the city's books.
Mhm.
And then over the last couple of years, that has actually gone away because it was, the HSA could be taken with, whereas HRA couldn't, but previously they had made that commitment to the employees, and then it was on the books, and we were getting I think it was like $5 per employee per month charge on it as long as they had it. And so we worked through, that was a couple of years ago that we worked through that. So that's no longer in existence. And then employees, once they get off the plan, they have the COBRA. And then if there's retirees that are on the plan, they pick up 100% of their costs. And they don't get there is no HSA contribution.
Can we go through the rest of this? Is there more information? Why don't we go through that? Because we're not deciding anything tonight. We're not deciding rates because we don't have renewals yet. I mean, we don't know that, so that your question's still in play, not dismissing it.
Yep.
Okay.
Okay. So the next part that we wanted to talk about is benchmarking. Where does your plan compare to other municipalities? So starting on page 9, and again, you have on the left-hand, upper left-hand, you're the dark color, the city is the dark, and benchmark is the turquoise color. So the important thing to realize there is you look like your plan is not as competitive as other municipalities, but that compares deductible. And so in a traditional plan or a conventional plan, deductible plus the co-insurance plus office co-pays plus drug co-pays equal the out-of-pocket maximum. If we drop directly below that to the lower left hand, you can see that your $2,800 deductible, which also, because of your qualified high deductible health plan, is the out-of-pocket, is right in line with everybody else. So your people may come to you and say, oh, my deductible is $2,800, and the city of Des Moines got a $1,250 deductible. Okay, that may be true, but the relative expense to the employee in any given calendar or policy year is the out-of-pocket maximum. That's the most they're going to pay out of their own back pocket in any calendar year. So again, at the lower left-hand side, you are right in there in terms of competitive with all municipalities. Any questions on that? This came up the last time and you wanted to see that. So if we just talk about the—
What's that far right-hand column? I'm sorry, I can't make that out. The HMA book, the turquoise one is like way here in the—
Out of network.
Out of network, that's.
Yeah, I was just gonna come in. We're looking at two benchmarks here because we know that you guys are competing for employees more than just other municipalities. The left-hand graph is other municipalities, which is 39 employers. The right-hand graph is Holmes Murphy's entire book of business, which is about 700 employer groups.
Just so, I mean, this is one of the handouts you guys, in-network employee, in-network family, out-of-network employee, and out-of-network family, and that's the same on that side as well.
So if we just look at the highlights on the lower right hand, most of the benchmark groups have a traditional plan, not a qualified high deductible. 15.4% of municipalities have a qualified high deductible. Out of the municipalities who have it, 82% have deductible and out of pocket between $2,500 and $4,000. The city is well within benchmark based on current plan design. Okay. On page 10, this compares the employee contribution on a monthly basis by, again, municipalities on the left, HMA book of business on the right. And if you just take a look at the single in the upper left, 12% compared to 13%. So your employees compared to other municipalities are paying 1% less in terms of their contribution to the premium. So on this page, on all four, wherever you see purple or the dark purple, that's your employees, and wherever you see turquoise, that's either municipalities or our book of business, and every single category, your employees are better. So now yeah, that's it. So any questions on benchmarking? This was specifically asked at our last meeting. So we wanted to give you this information so you can see clearly where your employees' plan design and their costs are in relationship to others.
I appreciate the benchmarking because it gives us a great sense of, are we in the same ballpark? And if we're going to lose some employees, probably to another municipality. So I think that's very valid to have. And I like it against your book too, because that's taking in even a bigger picture. So thank you. Please continue that part.
And part of the, when you look at the employee costs, so deductible is higher, out of pocket max is the deductible. When your deductible is higher, and that's the kind of the premise behind the high deductible health plan, is higher deductible, lower premiums. So when the employees are paying this max out of pocket, that experience, all that drives a premium. And then because of that, they're paying, it's
same as car insurance.
Right, exactly.
And I think it does, but just a question for clarification. Do these benchmarks also take into account the contribution that is made by the employer?
So this is just their, when we compare the contribution, it's employee to employee, right? It's not the total rate, if that's what you're asking.
No, the contribution that the city is making into the HSA.
No, this is just premium, or what we call the equivalent of premium for a self-funded case.
So if you're really doing a comparison, that's really—
You got to go up. Yeah, your people are going to if you're talking about the money that is going into their health savings account, that is not contemplated in any of these.
Thank you.
Yeah, that's really, really important and significant. Thanks so much.
That's a really great benefit.
Yeah,
there.
that's like,
That's a good recruiting tool right there.
yeah,
Exactly.
yeah.
Well, and it goes back to the philosophy
Right.
of the consumer-driven healthcare plan. It's this larger deductible, you have this contribution, and then the funding mechanism is the same as what the council and IMU board approved when this started. So the employees make that contribution and they'll get the match. And then when they manage that health savings account better and they're better stewards of their health, and they're not, they jam their pinky, they're not going to the ER, they're, okay, I'm gonna ice it, I'm gonna go to urgent care next. They're managing those claims better because they're managing their dollars better, which is then helping our plan and our claim experience, which then allows us to have these conversations about, okay, fund balance, and should we start drawing down on some of that stuff?
So Alicia will now walk us through COVID. I know you guys have a lot of information about it. We've got or you have a lot of questions about it. We've got a lot of information, how it relates to the city.
Yeah, thanks, Gail. So the next page are just looking at some plan design changes that were made. So as a lot of you probably know, there was a lot of legislation passed that required we make some things at no cost to the employee. The big thing with that was testing. So as of March 18th of 2020, the city is picking up all of the cost share for those COVID tests when employees are going in and prescribed that test by the provider. We also waived cost share for telemedicine providers. That way employees had the option to do those visits virtually rather than have to go in and see their primary care physician. So we did see a nice uptick in employees utilizing that service.
Is there a particular telemedicine provider that we require them to use, or can they choose their own? I'm just curious.
We got a slide on that.
Okay.
Yeah. The IRS did also make a couple changes, which really does impact you guys because you have that high deductible health plan. That HSA is really overseen by the IRS. A few things that the IRS did to help the employees out there allowed you guys to pay for the cost of that testing. Typically that wouldn't be considered preventive care, so that could make them ineligible. That was changed. And then the other piece is they allowed HSAs to now pay for over-the-counter medication, which prior to that you had to have a prescription from your doctor. So a few nice changes that the employees saw this year as a result of that. Those provisions were in place until March 31st, and I actually just saw today, Wellmark is extending those until June 30th now. So we have another extension where these will continue. Just a little information on the vaccine. The cost of the actual vaccine that we know today will be covered by the federal government. Where the health plan may have some cost share is just the administration of that vaccine when the employee goes into their provider and they actually administer that shot. As we get further into the vaccine process, Wellmark will start providing us reporting on that. So that's something that we'll look to share during our renewal meeting. So you guys will kind of get a pulse on, I'm sure you guys are more aware than other employer groups, but how many of your employees are vaccinated and what those costs would look like.
So just to reiterate her point, the vaccine itself, if I go to my primary care doctor, let's say the vaccine is $45.08. That $45.08 is picked up by the federal government, but the actual needle and the actual time to give my injection may come back as a charge. Isn't that interesting? There we go. And that needle is probably going to be as much as, no, just kidding. Sorry, it couldn't happen.
So the next page is actually some reporting that we do get from Wellmark, and this is including through the middle of January. So it is a little bit out of date now, but I don't think these numbers are super out of date just because we know testing has slowed down now that people are more concerned about getting that vaccine. You guys have had 68 members get tested, and the plan has picked up just over $11,000. Out of the members that have been tested, there have been a few positive cases, and the plan has paid just over $16,000 in expense on those. Really, the reason we show you these numbers is, the plan's expense due to COVID, we can see is under $30,000. So it's not as big of an impact as far as the testing and potential ICU cases and inpatient stays that we were worried about to begin with. The COVID costs have not really drug your guys' plan down, which we've seen from the claims.
Which is good.
And then telehealth and office visits. So we did have 64 people that utilized a telehealth visit, 175 different times. So the plan did pay $16,600 for those visits. The nice thing about that is we're seeing the cost of those visits is actually lower. So it's a benefit to the city and the board that your employees are going to those telehealth options because it's costing the plan less and it's costing the employee less.
Not just in hard costs, but travel time, parking if you're in Des Moines, you know, the ability to catch even further illnesses by sitting in the waiting room and et cetera. So,
Yeah.
which makes me, I get skeeves thinking about taking little kids to the doctor's office. You know, everybody's touching everything. She's pregnant.
So to speak to your question, employees do have a few different options. Wellmark does have a preferred provider, which is probably what you hear a lot about when they're promoting this service, and that's Doctor on Demand. And that's a fixed cost. It's $49 that the employee pays. If they've met their deductible, it's $49 that the city pays. So it's a very flat set cost. We know what that's going to be up front. If it's a mental health visit, those costs do go up just because the length of the visit goes up, but again, they're set in stone pricing. Employees do have the option though to see their regular in-network provider. So if their primary care physician has moved to the route of offering those virtual visits, they can go see their provider, go see them on a virtual platform, and then the provider submits that to Wellmark. So it's really either that doctor on demand option or they're seeing their normal regular doctor and getting billed for it that way.
And both would have contract relationships with Wellmark. So Wellmark has a fixed fee that they're going to pay.
Yeah. The other thing, just to point out on the slide, which you probably can't see very well, there is a pie chart which kind of breaks down why employees are going. And one of the great things that we're seeing, you can see that kind of navy blue color is mental health visits. So we know a lot of employees are actually utilizing these services for mental health. We want them to be doing that. If they were seeing a counselor or something like that before the pandemic, we want to make sure that we keep them going to that person. And I'm sure we've had kind of an uptick in new utilizers in that as well. So that's one of the great things that I think has come out of the telehealth option.
What is the PCP? What's that stand for?
That's their regular primary care.
Oh, primary
doctor.
care.
So that's going to
primary
be,
care
you
planner.
know,
Gotcha.
that's probably honestly people
Thank
that
you.
had COVID symptoms and didn't want to go into the
Gotcha.
office for the most part.
Okay.
Specialist, I would say, is likely dermatological type things,
Yep.
or if you are a cancer patient and you meet with your doctor regularly, and they've just switched those to virtual for the time being.
Okay, any questions on COVID and the impact to your, I think significantly less than what we thought a year ago today, right?
Mhm.
Our actuaries were predicting 49,000 per, when a year ago at this time, remember, our actuaries were saying 49,000 a hospital stay.
Per state?
Wow.
Yeah. So technology has caught up. I think the physicians got better. We've learned different things. So my last slide on page 14 are 2021 considerations. I want to walk you through that. Medical considerations. Again, we want to take a look at benchmarking, get your impact, get your thoughts on benchmarking. But I think you guys all clearly understand you are in the game, right? In the game. Stop loss analysis. We're going to take a look at the specific carrier because we had been with UMR. We moved to Wellmark, got additional pricing considerations from Wellmark. So we will look at that carrier and we'll also look at the specific deductible level. Today, you guys maintain $50,000 of every claim. So if I had a heart, lung, liver transplant and I was the city employee, only $50,000 of that would go into your claims experience. For that $50,000, we pay a premium. You guys all buy auto insurance. So as our 50,000 spec goes up to 75, the premium comes down. The more you guys retain, the premium comes down. The more you guys retain, the premium comes down. But I think I've said fairly clearly, we can expect a rate increase on reinsurance because we're in a pandemic and it is a global consideration, not just Blue Cross Blue Shield. So we will honor that as we always do and market and shop and bring you the best value.
If I can really quick, just that, and I think Courtney and Chris have had these conversations with like property and casualty. I mean, we're seeing that with our other insurance area. It's, you know, the ratio, pandemic, and those sorts of things are having that. So you will likely see that in some other renewals as well.
So we will also take a look at different drug programs. Wellmark has a drug plan called the Blue RX Value Plus. It's a specific program where there might not be as many tiers, but the pricing consideration, maybe 1.5 points, maybe a point. If we move to this, we'll take what we call a disruption analysis report to find out how many people would actually be affected. If we're going to talk about 70 people being affected, and if we only get a point on that, that's probably not a good deal. If we've got 5 people being affected, we're going to get 1.5 points. That's probably a good deal, but we will look at that as we do every year. We will look at self-funding versus fully insured every year. And we're having these conversations because you're self-funded because we have the ability to save premium dollars if we have a good year. But we want to make sure that that's worth the risk reward. If we get a fully insured quote that takes all this anxiety and angst away and saves us money, we're going to present that to you. Okay, so that's our commitment to you. We will review budgeting and accruals just like we always do. We'll bring you our budget model tool. We will tell you where we make our recommendations. If we fund to 60%, if that's too high this year, let's take a look at 50%, right? That's what we do. On wellness, the good folks here to my left have asked us to consider changing incentives to align with the medical plan year rather than the calendar year. Our medical plan year is July 1. Our calendar year, why wellness kicks in, is January 1. We've got 2 sets of 6 months here. Let's see if we can figure out how to get it on the same set of 12. All right, so that's our commitment. And we're going to take a look at looking at a larger wellness incentive for those that participate. The whole purpose of having a wellness program is to, best practices, best impact on myself. If I can save money, improve my health, I'm going to save money for myself as well as the plan. So that's the things that are on the agenda. We will start that as soon as we get all of the renewals in. We will schedule our meeting just like at the beginning of our slide 3 where we had the calendar year. So that is all we have to present tonight.
Ryan, my memory is fuzzy on this, but it seems like there was some discussion about changing to the calendar year for health insurance. Am I remembering that correct? And that just kind of gone away?
You are remembering that correct. So that was in the early stages of when we did the plan design change. We looked at the plan design change, and then so Rob, I think, was still here, yeah. And we talked. Rob had wanted to pursue that. It made sense. Then Rob left, and then Tom came on, and then when we started talking with. I can't remember when Tom came in. If it might have been right as we were going through renewals or something. But when we talked to Holmes Murphy again, and correct me if I'm misstating, but the downside to going to the calendar year was going to be everybody else. Most of their book of business was on that calendar year as well, and so rather than having the ability for these insurance companies to look at our stuff now in May and April. When they have more time, they can kind of scrutinize a little bit better, and then it has been playing to our favor. So
yeah, about 60% of all business in Iowa renews in January 1. So it's kind of this huge deluge of, like last minute Christmas shopping or something. So we just kind of talked through it and elected to say on the 7/1.
So there wasn't a more strategic decision to move to that. It was more just convenience that was felt.
Yeah, I mean, there's some
a little, can be a little dicey on the calendar year versus switching it up once it's impacted.
Sure.
I mean, and that's the thing. I mean, in the 20 years I've been working on this type of stuff, it's explaining the difference between the deductible year and the calendar year, and like, oh, but our plan year is July, but how come our deductible doesn't get reset?
And most every municipality in Iowa is a 7/1 renewal. Schools, cities, counties, it's just kind of how the convention has happened.
That makes sense.
Budget, yeah. So that's us for now. You have any questions? Do you have anything you want us to think about for consideration as we march through the 21 renewal? Is there anything I can address, anything I can answer for you, anything I can help clarify? Anything you want, you can email me privately. Anything, we're here to help.
Good. Thank you.
I want to say thank you to both of you. Very thorough, very informative, good explanations. Thanks for including that COVID piece as well, because you're right. We can just make guesses. Well, now we have facts. So thank you very, very much. Also to the team, thank you for getting this out early to all of us, so we had time to look at it, digest it, come prepared with questions.
Yeah, I'm just gonna say one last thing. You guys, pat yourself on the back. This has been quite the accomplishment.
Yes,
I mean,
agreed.
you know, you start when we look where we were in 2013 and we were on this
Mhm.
spiral like that looked like this. And now we have like a wonderful opportunity to have great discussions on how well we've done. So that is a tribute to this group and everybody and all the employees.
You're right.
I agree. I agree.
Well,
Thank you.
we also sadly lost a few
Is there
employees
any
that
other business that needs to
affected
come
that
before us
hugely.
tonight? Hearing none, seeing none, I'll take a motion to adjourn.
Motion to adjourn.
Second?
All
That
those in
was
favor
quick.
signify by saying aye.
Aye.
Motion carries. We stand adjourned. Thank you very much.
Thank you.
Appreciate everybody.
Thanks, everyone.